Good morning, members. We will start in the next 3 minutes. Thank you. Good afternoon, members. I think we should start. My name is Vyokas Machalamba. I'm the Committee Secretary for the Portfolio Committee on Health. I'm going to start by introducing my colleagues, and I will request them to stand when I introduce them. In that corner, it's Mr. Zubair Rahim. He is our committee researcher. Next to him, it's Ms. Lindokuhle Ngomane. She is our content advisor. At the back of the venue, it's Ms. Nombali Makubane. She is the committee assistant. Next to Nombali is Ms. Tsotseka Sotsishe. She is the secretary to the chairperson. I am Vyokas Machalamba. I am the committee secretary. Just to make sure that we have all the members in the meeting, I'll call out the register so members can indicate when I call their names. I'll start with Dr. Dlomo.
Present.
Thank you. Ms. Kilwe.
I'm present.
Thank you. Ms. Semne. Ms. Sene.
I'm present.
Thank you. Ms. Shabangu.
Present.
Ms. Kumalo.
I'm present.
Thank you. Ms. Clark.
Present.
Mr. Leroux.
I'm present, Dr. Leroux, thank you.
Oh, thank you. Sorry about that. It's written, Mr. We'll correct it. Mr. Motubatse. Mr. Twabaza. Thank you. Dr. Tembe Kwayo.
I'm present.
Thank you. Mr. Van Staden.
I'm present.
Thank you. Dr. Litlape.
Present.
Thank you. Mr. Zungula. And Mr. Mhlongo. We will continue with the business of the day. Just to remind members, I'm not sure if they received the WhatsApp, but on our agenda today is the election of the committee chairperson, followed by the briefing by the Department of Health on the annual performance plan and the budget. So we will start with the election of the chairperson. Then after at 12:30 or so, then the department will come and present its annual performance plan and the budget. According to Rule 158 of the National Assembly rules, the committee must elect one of its members to be the committee chairperson. I will then call for nominations. Yes, ma'am. It's only permanent members who will be able to vote and to nominate members. So if you are an alternate member, you won't be able to nominate or to vote in the committee. Can I request the permanent members to nominate the chairperson? Alternate. From the permanent members? Thank you. Over to you, ma'am.
Thank you very much. My name is Marcel Lawson. I would like to nominate Dr. Sibongiseni Dlomo. Thank you.
Is there a seconder? Yes, ma'am.
Thank you. My name is Betty Kihakilo. I would like to second the proposal of the name of Dr. Sibongiseni Dlomo. Thank you.
Thank you so much. Dr. Dlomo has been nominated as the chairperson of the committee. Dr. Dlomo, do you accept the nomination?
Thank you very much to those members who have raised my name and seconded it. I am available to serve as the chair of the committee. Thank you.
Thank you. Are there any further nominations? There are no further nominations. Dr. Dlomo, you are now the chairperson of the Portfolio Committee on Health. Congratulations. You can come and take your seat.
Thanks, Vidi.
Thank you very much. To my colleague who are here as members of this committee, I would like to express our sincere thanks for actually supporting my name. It's a responsibility that I will share with you. I want to start by saying in this committee we are greatly appreciative of having a chairperson, a secretary next to me who has really been in this committee at least for over 10 years. She used to be like a challenge support when some of us were MECs in various provinces. I'm also grateful to have Honorable Dr. Thembekwayo here, because this is her third term. When some of us were doing work in provinces as MECs, she was in the 5th administration already a member of this portfolio committee. And also in the last term, she has been there, and now again. So we really are enriched greatly by these honorable members. The other member who's returning and is the second term is Honorable Van Staden. He has also been here. This is his second term as a member of the same portfolio committee. We are greatly honored also that Honorable Clark is a returning member. So colleagues, we are rich with resources in terms of the support that we have. We welcome the new members, and this is a home. What actually has been very important with these members is that when you deal with issues of health in the country, it's a very sensitive matter. It cuts across all the political divide. You can't go to Soweto and want to service a clinic that is serving IFP or DA only. It's citizens of our country, so we have that responsibility. Once again, thank you very much and welcome to all members who are new. We will also be all of us new, but I was pointing out these members who have some experience of this portfolio committee. The lady on my right is a very difficult lady. If she's following the rules of parliament, if you try to bend them, we have a challenge and a difficulty. So let me pause there now and thank you very much to all the members, and you'll guide me whether we'll have to wait for 12:30 or we'll get them to come in early.
I'll try and see if they can come in, but in the meantime,
Yeah.
we can take a 10 minutes break, then I'll call them.
Okay. We will probably then take a pause. Some colleagues were asking, can you go and grab coffee, tea, water? Maybe let's do so. And let me just ask first, are we allowed to bring tea inside? Yeah, she's a very strict one, must always ask. So for those who like to get tea, coffee, water from outside and some snack, let's do that, because I understand there are some people who are going past our passage and they think that snack is made for everybody and it's meant for this committee. Let's grab what we have and then have, thank you very much. If the department comes much earlier, we will start early, but they were told 12:30. Thanks. Honourable members, we have since been joined by Honourable Mshongo. She is allocated to be in this portfolio committee from her party, the African IFP. Thank you. Welcome, Mam Mshongo. A short break, 10 to 15 minutes, and we'll reassemble when the department is here, and then start. Honorable members, before we start, I want to check logistically. They've just brought in lunch outside. And then the first item from us as members will be to a bit listen and write. We do have a challenge to grab lunch and come inside. And we then have lunch while we are listening. Let me just check if that will be fine so that we don't keep it there longer and it's going to get colder. Is that a yes? Okay, members, it's on the member. Season is on this side, just to grab and come in, and then we start. Honourable members, I have been advised that it's better we eat outside because this meeting is going very far. Okay. I think from our side, as honourable members, we now are a full house. Hopefully, the staff of Ms. Machalamba will also join us, because she had more than four warm bodies there. But the main important part now is to start. May I then report into this House that I've been humbly nominated by the honourable members in this House to be the chairperson of this Portfolio Committee of Health in this 7th administration. And I've really expressed my sincere thanks to all of my honourable members coming in from various political parties with this gesture. But let me then, so that the department would know who are the members who are here, though we have also some veterans members who are coming back for the second or third time, start to get them to introduce themselves. I would like to start with Dr. Thembekwayo, Honourable Dr. Thembekwayo sitting here, then we're going to end right up on the other side. Honourable members, thank you.
Thank you very much, and congratulations, our chairperson, for the coming 5 years. I'm Dr. Susan Thembekwayo. I'm a member of this Committee on Health, coming back for the 3rd time now. Thank you.
If I may add, for the first time, the chairperson is giving you permission. Do mention I'm Dr. Thembekwayo from the EFF, right through, because the colleagues would know. Let's mention that at least for today. Permission given.
Okay, yeah, for today. I don't know, maybe after tomorrow, but I'm a member of the Economic Freedom Fighters. Thank you.
Thanks. I'm Nompumelelo Mhlongo from IFP, and I would like to congratulate Dr. Dlomo. I know Dr. Dlomo for quite some time while we were working for the Department of Health. Thanks.
Thank you, Chair. And let me also congratulate you on your new adventure. My name is Betike Khakilwe, and I am from ANC. Thank you, Chair.
Thanks, Chairperson. Let me also join the other comrades in congratulating you and wishing you well in the next 5 years. Fisani Shabangu from Mpumalanga, under the cap of ANC. Thank you.
May I request Honourable Mhlongo just to switch it off there.
Oh, sorry.
Thank you very much, Chairperson. My name is Juliet Kumalo. I'm from the African National Congress, and thank you very much, Chair, for accepting the nomination of being our chairperson. Thank you.
Member Philip van Staden from Freedom Front Plus, Chairperson, congratulations on your election. Just a word of advice, please don't run away like the last time. Just stay here. But congratulations, and it's nice to see the old faces back again, and I think we're going to have a wonderful time. Thank you.
Congratulations, Chair. Lona Reverend Tlantla Cwabaza from the MK, Waza Mkhonto.
Good afternoon. My name is Michelle Clark. I'm a member of the Democratic Alliance and served on this committee last term as well for half a term, I would say. And congratulations to you, Dr. Dlomo. I think this committee worked very well together in the last term, and hopefully we have that same way of working. And it's great to see all the staff again, and Vuyo and her team. We had a very good relationship with everybody on this committee, and you know, we did fight with each other about things, but we always walked out here united, and I hope that is how we're going to be in that spirit going forward. Thank you.
Thank you, Chair, and congratulations on your election. My name is Dr. Carl Leroux. I'm from the DA, and I regard myself, even though I now am in Cape Town, as a rural doctor, and I spent the last 16 years working in the deep rural Eastern Cape. Thank you.
Good afternoon, Chair, and congratulations on your comeback. My name is Khosi Letlape. I'm an ophthalmologist by training and a health activist by choice. And I'm here representing Action SA. Thank you, Chair.
Thank you very much, honorable members, and thanks for all your warm comments that you made about me. When someone says good things about you, you really have to make sure you live up to that, what a person wishes and actually expects out of you. Our item on the agenda, honorable members, is to, as you probably know, that on Thursday the 11th, we will have a debate on this health vote 8. Is to start listening to this department. What are you up to? What are you doing? We are really going to then get the annual performance plan and also get their budget projections. Of course, their budget was actually given by us in Parliament to say, whatever we are saying we are going to do, here's the budget, go do it. Now, we have a plan against that budget. We are aware that there are pressures that are actually challenging the minister, but we'll probably hear more from the DG about that. We will allocate DG not more than 45 minutes because we need members to still engage with your presentation and allow them and you coming back again to clarify some of the things that they will raise. Maybe you will start by introducing the team that you lead, and so that members, especially some of the new members, might know who are you, Shenge, Sizwayale, Makai, Kolamtani, introduce the team, then you then start the presentation. I'll be assisted by Ms. Machalamba to time you. Don't go more than 45 minutes to allow our members to interact with your presentation. Thank you very much.
Thank you very much, Honorable Chair, honorable members. Let me start by also saying congratulations to the Chair. Let me convey the apology on behalf of the Minister. Unfortunately, there is a first special cabinet meeting that started at 12 o'clock and he couldn't be able to get out of that meeting. And also our Deputy Minister, Dr. Joe Pasha, who's out of the country on some state duty. He'll only be back towards the end of this week. I am accompanied, Honorable Chair, by Professor Nicholas Crisp, who's our Deputy Director General for National Health Insurance, and also our Chief Finance Officer and also Deputy Director General, Mr. Paswa Phineas Mamokhale, who's our Chief Financial Officer. Then Ms. Koketso Sebanyoni, she's the brains behind most of the planning work in the department. And then we also have the two parliamentary liaison officers from the Minister's Office, Mr. Joe Khatla, and from the DG's office, we've got Ms. Mkize. And then we've got our departmental spokesperson and media liaison, Mr. Foster Mokhale, who are accompanying us today. With your permission, Honorable Chair, I will start with my presentation. I'll do the first part, and then the CFO will come in with the numbers to support what I will be presenting.
Before you start, DG, honorable members, if there's anyone that you need to remember most in this department is Mr. Khatla. Khatla, raise your hand. Your lives will be very easy, smooth into the department. If they all frustrate you, get hold of that gentleman. He will then be able to smooth you into the department, and all our challenges will be sorted out. He will then have to volunteer his number to the members across here when you leave this meeting. Thank you, Khatla.
And Honorable Chair, my name is Sandile Sabelo Siyabonga Buthelezi. I'm the Director General of the Department of Health. Firstly, just to, this is the annual performance plan that we had to table in Parliament in the previous administration as per the statutes of the country. And it's really premised on what we called medium-term strategic framework 2019 to 2024. At that time, because we've not yet worked on the new plan, we're already working on that as foresight and going into cabinet this weekend. But our priority is number 2 of the 7 priorities of the MTSF, which is education, skills, and health. And the vision of the department is a long and healthy life for all South Africans. And what are the impacts that we're looking at? It's to improve life expectancy of South Africans to at least 66.6 years by 2024, which is this year, and 70 years by 2030. We'll talk a bit about this because we had a knock after doing very well following the implementation of the antiretroviral program, but COVID took us back, but I think we're picking up again. Then the second one, it's the most important one for us, is universal health coverage for all South Africans, progressively achieved and all citizens protected from catastrophic financial impact of seeking health care by 2030 through the implementation of the National Health Insurance. And the context of our plan really is looked, one, we know that we did have a knock. We went down to about 58 during COVID, but we've picked up now to about 62.2, and we believe we'll be able to accelerate that through the number of programs that we'll touch on, but also in terms of congesting our facilities, our central chronic medication distribution program is actually doing very well in terms of getting people to get treatment closer to their home without having to pay more money. We have also learned from COVID, and we introduced the 10th pillar of the health compact, the pandemic prevention, preparedness and response, so that we are not caught off guard should we get another epidemic as a country. Of course, I'll talk a bit on the burden of non-communicable diseases, which continue to increase largely due to adoption of unhealthy lifestyle. We are committed as a department, and during this administration, we will actually be aggressively implementing the National Health Insurance after it being assented into the Act by the State President of South Africa. Our key focus area for this year is one, is the National Strategic Plan for HIDB and STIs, so that we reach our 95 targets, meaning that 95 of people who are HIV positive, they know that they are positive. Those who are positive, at least 95% of them should be on treatment, life-saving treatment. Then those out of those 95 who are on treatment, 95% of them must be virally suppressed, meaning that the virus should not be detectable, should at least be less than 1,000, but better at less than 50 copies per mil within the blood. The third one is quality of healthcare, which is the main issue why we always have complaints, that we have key interventions to improve that. Our facilities is a key area that we're also focusing on to ensure that our infrastructure is well managed. Now, our communities need to be part and parcel of the solutions, working with them. So promoting participation is one of our focus areas in this administration. Maternal and infant mortality, we need to sustain the reduction. We've had a reduction, but it's not getting to where we want to be specifically in terms of the Sustainable Development Goals. So we want to sustain that. We need to be aggressive in capacitating critical functions so that we are able to move quicker and faster with National Health Insurance, which is a key equalizer and one of the major reforms that government will be implementing. Then we need to, this term also will be working on the hospital strategy, which we wanted finalized, approved by the National Health Council to ensure that we improve leadership, management and governance of hospitals. Now, what are the key issues that we put in our annual performance plan? In terms of program one within administration, of course, we need to gain the public trust. We need to ensure that our financial management is tops. So hence, audit outcome for us is one of the most important things that we do need to have an unqualified audit, both on finance and also on performance information. Key issue has been in the newspapers for the past 2 days is the payment of invoices within 30 days, valid invoices that come to the department, that we should have no invoice that is not paid within 30 days, so that we contribute to the SMMEs being able to actually develop and do job creation. Health promotion, our health system is very curative in its current form. So we need to ensure that we get out and promote health through all the areas, be it audio broadcast media, commercial media, social media, community media. Visits to facilities specifically by our leaders, the Deputy Minister and the Minister, especially unannounced visits, that's critical. We are actually giving them a target that they need to get out there and see for themselves what is happening in the facilities on the ground. And then also in terms of community engagements, either through the National Health Consultative Forum, which is legislated in the Act, or is in BIZO, not just specific to health, and sit with communities and hear from them what's happening. And then on employment equity, we've got some targets which are linked to the Department of Women, Youth and People with Disabilities, that we need to ensure that at least within SMS level, SMS is from director and above, at least 50% of those people should be women. But we also need to promote youth employment. At least have about 30% of youth being employed in the department. And of course, people living with disabilities. Although there is a target for 2030 that has been set, we are actually dissecting this target. And we think this year we must aim at 2.5%, and we must be deliberate when advertising that people with disabilities and actually ensure that some jobs are really ring-fenced for people living with disabilities. The next one is on National Health Insurance, which is Program 2. CCMDD, which is a Central Chronic Medicine Dispensing and Distribution. As I mentioned, we want at least to reach 9.5 million people. Initially, this was mainly for HIV and TB patients, but now we've extended it to all other chronic diseases, diabetes, hypertension, or any other chronic disease that people are able to go to pick up points closer to them once they are stable and pick up the treatment. We also, this year, we want to have a framework for accrediting health service providers as part of the implementation of the National Health Insurance. That framework must be approved by the National Health Council. There's work being done on the capitation model, which is a reimbursement model that we're going to be using for PHC, which is a risk-based capitation model. We want to move away for fee-for-service. There's work that we're doing in this area, and we want this framework to be finalized. There's work led by Professor Chris being done in all the provinces, just to see which involves both public and private sector as we move forward. We are also, this is what we've always been working on, that we do need to have an electronic medical record, which is one of the areas that's problematic for us as it comes to even medical legal claims where people records gets lost. We are quite advanced. We've just had a presentation, and we believe very soon we're going to have a record that a person from birth to death will have, and whether they're in Gauteng, whether they're in Kimberley, whether they are in Northwest, that record is available electronically. And lastly, here we're looking at having at least the essential equipment list for healthcare service package that we will have approved by the National Health Council. 3, which we look at communicable and non-communicable diseases. Here, again, it's still linked to getting people decongesting the facility, which is putting people on differentiated models of care so that people are on different models of care, whether they do pick-up points or whether they still go to facilities or other areas. So we currently have about 2.7 people that we've decongested, and others are on 3 months dispensing, others are on 2-month, multi-month dispensing. Our target, we're looking obviously within the permits of the law. If we can go into 6 months dispensing for those who are very stable, so that we only see them once in 6 months, you do the viral load, they don't have to be coming to facilities every month. It also helps them in terms of healthcare expenditure. With the youth zones, we're looking at ensuring, this really is to ensure that the adolescents in the facilities, they've got safe spaces, they are able to be treated and are able to access the services, being the sexual reproductive health services or any other services without fear. So we're looking at least 2,200 facilities that we want to be working on. Here, TB is still a problem, and TB has been a leading killer for a long time until it was displaced by COVID. And slowly now it is being displaced by diabetes. We'll talk about, but it's still a problem and it's curable. So we really need to ensure that at this drug-sensitive TB success rate, we reach 83%. We're currently sitting at about 71%. We had a bit of a knock during COVID, but we think with the TB recovery plan, we reached that. In terms of drug-resistant TB, we're looking at going to 73% success rate. The success rate is measured in terms of treatment completion and a cure rate. If you combine those, you get a success rate. We're currently sitting at 60.8%. We'd like to go as high as 73%. We've improved because this has been a problem for the country. We've introduced better treatment regimens, shorter regimens. We don't have to admit you in hospitals, and most of that work was done here in South Africa. Also, getting the people that are having TB and not on treatment, we want at least to find about 221. This is based on the work that we do, that we know that we have a lot of people who have TB but are not on treatment, and those are the people that are a problem, that are actually spreading TB. We're sitting at currently about 180,000, and we think we need to find at least between 30 to 50,000 of those people and put them on treatment so that they are cured. And then human papillomavirus screening. Human papillomavirus is a key virus that is actually, some of their genomes are linked to cervical cancer and some other cancers as well. So we have now moved to from what we do cytology screening, where you do a pap smear, you go and put under the microscope. We're now doing HPV. We're transitioning to HPV screening. And cervical cancer, the commonest cancer in women is a breast cancer. But sadly, in African women, it's cervical cancer. And it's also linked with HIV because it's also an AIDS-defining illness. So we're moving at least to 18 districts in this financial year to introduce it. Why we're introducing HPV screening? With the cytology-based screening, people still came, we still saw a lot of, we did not see an improvement in picking up people with cancer. And then the scientists worked out and saw that let's rather focus and look on HPV itself because it's a major determinant of the cervical cancer. Then on the non-flaccid paralysis, this is really linked to polio. We are actually certified polio-free, so we'd like at least 45 of the 52 districts not to report more than 2% of non-acute flaccid paralysis per 100,000 for children under 15 years. Next one is non-communicable diseases. Here, the problem, this is a major problem. It's a next epidemic that we're going to face. And we normally call it a 5x5. And our former deputy minister, that was one of his areas he was focusing on in the department. You're looking at 5 conditions. And those conditions, it's one, it's cardiovascular, mainly linked hypertension and its problems. Metabolic, which is diabetes, as I said, is now overtaking TB as a major killer and its related problems. The third one, it's lower respiratory tract infections that are problematic, the malignancies, the cancers, and the last one, the big one, is mental health, which is a problem. And they are linked to 5 causes. One is a sedentary lifestyle, that's lack of exercise, which it's something that you don't need medicine to do. The second one is your diet, mainly high salt intake, trans fatty acids. It's a problem that is there. 3, it's smoking. 4, it's alcohol and drug abuse. 5, it's the air you breathe in the areas, the environmental pollution. So if you manage, that's why I call it 5x5. And all these things, if you manage them, they are all non-pharmaceutical. You'll be able to deal with this matter, but we are not dealing with it. That's why it's called diseases of lifestyle. These are all the targets that we have there that we are moving in terms of the non-communicable diseases. Then in terms of primary health care, we have the ideal clinic program. And we also now have introduced the ideal hospital program. We're looking in the hospitals, at least this financial year, because it's new, we're looking at 25 hospitals being qualified as ideal, and clinics we want to go up to 2.7 of those clinics that we want to be ideal. Then in terms of the community outreach services, specifically in terms of community health workers, which we have about 47,000 in the department, we want them at least to reach 14 million households in terms of health promotion, maybe getting them, those who are lost to treatment, and just mainly on health promotion though. And then in environmental health, it's very critical for us, as probably honorable members will note that we've had a lot of issues, even with the illegal spaza shops, kids eating something. So we need to be building that capacity and ensuring that, because it's in the municipalities, we work directly with national, but we work with those those municipalities to ensure that they actually comply to the norms and standards in terms of this and develop the tools for that. But also with emergency medical services, it's a major area. We do get a lot of questions from the portfolio committee in terms of the performance. So we do our own assessments with the provinces in terms of their compliance with the regulations that we've put in place. Then in terms of hospitals, we want to develop a proper hospital strategy this year, both for different levels of hospitals, be it a district hospital, be it tertiary, be it central hospitals, and ensure that they work within a particular strategy so that we don't get all the complaints that we get. But then national quality improvements, we want all our facilities to be implemented. Of course, we do have a national quality improvement program. And then in terms of the infrastructure, the many areas we're working with, we're either working on new hospitals. There's a number of hospitals that are under construction that we want to move. You know, the construction is a multi-year program. Some are in Limpopo and some are in the Eastern Cape currently that we would like to move. But we're looking at least if we put, and those that are revitalized, that's major revamp, spending lots of money and probably overhauling a unit in maternity and putting a new unit. That's why we call it revitalize. Or minor, just minor renovations where we're looking at about 400 facilities, both hospitals and clinics, where you just do patch-ups there, it's just to ensure that the facility meets the particular standards. And then on program 6, that's where we deal with our public entities. As we are aware, public entities, their accounting authorities are the boards. And the function of the minister is really to appoint those boards, ensure that the regulations are in place, and ensure that they perform well. So we do have a few facilities whose boards, we need to appoint new boards in this financial year, and we've put them there. One is SAPRA, which is South African Health Products Regulatory Authority. The second one is NHLS, which is National Health Laboratory Services. Third one is SADTC, which is South African Dental Technicians Council. And we're also monitoring their performance in terms of audits. They do come individually to present to the portfolio committee, and when their audit actually plans as a department, we have a responsibility to oversee that they do that work. And then in terms of nursing services, it's in terms of number of differentiated nursing education and training plans that they develop. We all know now with the nursing training program, we've now moved and we're working with higher education, and all the provinces have had to develop the plans, both in terms of the new programs that we've put in place to train nurses, but also in terms of postgraduate training for nurses. So these are the plans that will ensure that the 9 colleges, because each province has got a main college with sub-campuses, so that they are able to get those plans, whether it's advanced midwifery, whether it's theatre nursing, whether it's occupational health nursing, those programs. We do manage, we do have an office called the Chief Nursing Officer that are responsible for the 3 areas of nursing, which is practice, regulatory, and education. Then the last one here is on food control. We do have a unit that deals with food control, and the main issue we're going to be dealing with here, as I did mention, that one of the problems with non-communicable diseases is a diet, and it's what we eat, is what we put into our mouths, is what is in that food that we eat. So we do actually have regulations with a lot of resistance coming up that the food needs to be labeled in a particular way, so that if you eat that pie, you know how much trans fatty acid it has, how much salt it has, how much sugar or whatever you're eating it has. So we're working on that, and it's quite advanced. I know we'll be going through NETLEC, and it will finally then come up so that it gets. But also it helps now, because some of the things that these spaza shops sell, they get through the country, they don't have proper labeling, and they come in, people don't know what they're eating, then we get people getting sick. So we're moving quite faster on that to be able to make it happen in this financial year. So in terms of the key outputs, which is my summary slides, on program 1, really we want to strengthen financial management and ensure that valid invoices are paid within 30 days. And we want to ensure that the health system responds, and it's also reaching to the people through the community engagement. Function 2 this year, the main critical function that we will be doing with Professor Crisp leading as the DDG, is that we need to ensure that all the work background work that needs to happen for us to move forward with NHI happens during this administration, actually this financial year, not the administration. On program 3, we're looking at access to medicine, improved through the differentiated models of care. We want to see progress towards TB accelerated through TB acceleration through improving treatment outcomes for TB and the screening for non-communicable diseases for early detection and treatment. Then program 4 is mainly community outreach services to households for tracing and linking patients to care. But one other area here is really focusing on mental care, on mental health, which is becoming a serious epidemic for us. Program 5 is health facilities maintenance, refurbishments, and the improved performance of hospitals. Then program 6, we want to be looking at ensuring that all our entities, our Section 3A entities or the PFMA entities under the Department of Health, they do their work by ensuring that governance is properly done from the department. Honorable Chair, with your permission, I hand over to the Chief Finance Officer.
Good afternoon, Honorable Chair and Honorable Members. Thanks, DG. I'll go through the few slides on the budget allocation. So the first slide is on the summary per program. So to indicate that the total budget for the department in the current financial year is 62.2 billion. That's on the last column. Then we also do indicate the source of funding for the department in terms of voted funds. We have 1.2 billion. We also have indicated in terms of each program, then in terms of earmarked funding is 2.4 billion, and conditional grants, which is the transfers to the provinces, is sitting on 56.3 billion. And also we do have the indirect grant in the department, currently sitting on 2.1 billion. Then in total is the 62.2 billion. In terms of the summary, in terms of the economic classification, just to indicate where we have allocated the budget in the department, our compensation of employees is 694 million. Under goods and services, we're sitting on 1.7 billion, and also on transfers is 58 billion, but we'll also indicate, as you'll see, under conditional grants, the money that goes to the provinces is 56 billion. We also do have 2 billion that goes to the entities and also the NGOs. So the slides that will follow to indicate the allocation thereof. And in terms of capital, we have 1.4 billion, which then the total it still come to the 62.2 billion. The next slide, it only indicates in terms of the movement from the previous financial year, in terms of the net change from our baseline allocation that has decreased by 225 million. So you'll see in terms of compensation of employees, it has decreased or reduced by 15.9. In terms of goods and services, it has been reduced by 146. So in terms of transfers and subsidies, there was an increase in terms of our conditional grants by 180 million. And also there is a money that we received, which was shifted from the Department of Science and Innovation. And our capital, it has also been reduced by 107. The details will also come as we proceed with the slides. On program 1, we also, under earmarked funding, just to indicate, we also still have the funding to deal with medico-legal committees. We also have the SAICA program to support the provinces in terms of financial management. Also, in terms of economic classification, we still indicate, but the total allocated to program 1 is 795 million. In program 2, as DG has indicated, so you'll see the money that has been allocated is 1.3 billion. So under our voted fund, we have 71. Earmarked, we have 59.9. But under our conditional grants, we have 455, which is the NHI conditional grant. Then under the indirect grant, that's where we have the funding for some of the NHI indirect grants, like our patient information system, our medicine stock systems, internships, and community service, CMDD, which the DG has indicated earlier, and also the Ideal Clinic to support the Ideal Clinic and the quality improvement in the facilities and the GP contracting capacitation. Then the next slide, we show the same expenditure in terms of the economic classification. You'll also see that 455 under the conditional grants. So those are all the monies that goes to the provinces. And under program 3, you'll see the bigger money there is 24 billion under conditional grants. So that is the money that goes to the provinces in terms of the conditional grants to deal with the HIV and AIDS. I think towards the last of the slides, we're going to show the allocation to the provinces in terms of the conditional grants. We also do have the NGOs, the allocation that we do in terms of the Lifeline, Love Life, Soul City, and the others, including the SANEC. Then the next slide is in terms of our economic classification in program 3. And in program 4, which is our primary health care, we do have 3.2 billion under conditional grants. So that is the money that goes for the community health care workers under the district health program. And then the next slide, we're also indicating our economic classification in terms of program 4, and in terms of program 5, hospital services. We do have the health facility revitalization conditional grant, which is 1.7 billion. So that's the money that goes to the provinces, including the 15.2 under the NTSG to support the tertiary services, and also the 1.4 under the indirect grant, which is the one which we are assisting in terms of building other facilities in the provinces. We also do have the same slides in terms of the economic classifications in terms of hospital systems to the total of 23 billion. In terms of program 6, which is our health system governance, that's where we also find in the HR, the Women Resource and Treasury Conditional Grant, where we having the 5.5 billion going to the provinces. It also includes the money that we pay to the entities, as we have seen in terms of the targets. Then those are the allocation to some of the entities of the department. And the next slide, it shows therefore the economic classification in terms of the program 6. And Chairperson, on the next slide, it shows that 56 billion in terms of the allocation. So we're having the conditional grant. So this is the money that we transfer to the provinces. So we have the National Treasury Services Grant, and oncology we're sitting on 15.2 billion. Then we have the National Health Insurance Grant, which is 455 million. And in terms of the revitalization for infrastructure, 7.1. The statutory HR resource and training grant. So that 5.5 billion, it includes the below 2, which is statutory HR resource component, and the training component of 2.5 and 2.9. And when we go to the next grant is the district health program grant, which is 27. So that 27 is made up by the last 2, which is comprehensive HIV and AIDS component, and also the district health component, which is 24 billion and 3.2 billion to the total of 56.3 billion. So the next slide, Honorable Chair, we actually then indicated the allocation to the provinces in terms of each grant. I'll only indicate the name of the grant, which is the NTSG, with the totals that I've indicated. Then the next slide, in terms of the NHI, is 455. So I'm not reading the allocation per each province, but we have the allocation for all the 9 provinces. And then in terms of the next one, the next grant is the Health Facility Revitalization Grant, where we're having 7.1 billion. And the next slide on the 5.5 billion is the one that includes the HR component, which is 2.7. So we have all those allocations to the provinces. And the next line, which is then the training component, which is 2.9 billion. Then we do have the allocations per each province, Chair. Then the last grant is the district health program grant. So it's sitting on 27. Those are the allocation per each province, as I've indicated. It's made up of two components, which is number one is comprehensive HIV and AIDS component, which is sitting on 24.7 billion in the current year allocation, while the last component on the district health component is sitting on 3.2 billion. So that is the allocation, Chair, in terms of the allocation that we have received. Thanks, DG.
Thank you very much, CFO. So, as a closing remark, Honorable Chair and Honorable Members, we carry almost a 62 billion budget. We take 56 billion into the provinces and just above 3-4 billion to the entities. So, we only left for operations with quite that. So, we still give it to provinces. And what I also wanted just to explain, especially if there are new members, is the difference between a direct and indirect grant. An indirect grant is a grant that we get as national and we implement from national. The one that we say direct, we take it to the province. So we sign a performance agreement or they give us a business plan in the province. For example, for infrastructure, they will say we've got clinic A, clinic B, hospital so and so that will revitalize and this is the money we're going to spend. And then they submit that to us and then I sign an agreement with the HOD. Then the CFO gives them money every quarter based on performance, so that towards the end of the year, if there is poor performance, we are able to move money between the provinces so that that money does not go back to National Treasury. That is a direct grant. And it's really managed by the province based on an agreed business plan. Thank you very much, Honorable Chair and Honorable Members.
Thank you very much, DG and your team, CFO. Honorable Members, as DG was summarizing, what normally happens, just to get all of us into speed, is that these funds are voted by ourselves as parliamentarians. The department comes with a plan. We don't make a plan, they make a plan. That we want to service the citizens of our country in this way. And we are requesting a budget of this size to do those things. And hence that budget therefore got voted and sent to health. So like many other government departments, they've received 62.2 billion for the activities that they plan to have. We then have a responsibility to go and do oversight and make sure that they do according to the plan that they actually have produced. Because later in the year, we are going to do an annual performance report. We are going to get an annual performance report to say, you got this, and you have a plan, what have you done? So for today is to work on and really listen to your wisdom in terms of the plan that they've put together, and they actually interrogate it and then get clarity-seeking questions and comments when the budget that have already been allocated to the department. I will then open up this opportunity. We were supposed to finish at 2, but I've since requested that they extend, but not later than 3 o'clock, because when we ask or clarity, they will still have to respond. We need to be leaving this place just before 3 so that we can allow the venue to be used by another portfolio committee. Okay, let me then take the hands from honorable members. And because we are also still new, when you start your contribution again, please just say it again, who you are, and then we could, let me then for now take hands. Give you numbers, colleagues. There's a number here from number 1 from Northwest. Look at me so that I can really allocate it right now. You had your hand first, 1. Then number 2 will be Van Staden. Number 3, I go back to. We would love to see your mask. We would love to see your face without a mask. It's just once off. Yeah, we'll go to the honorable member with the mask on. And number 4 will be Clark, Honorable Clark. Number 5 would be Honorable Dr. Loom. There's nothing coming from Dr. Litlape. Okay, Dr. Litlape are number 6, and our veteran will be number 7. All right. In that order, colleagues, still to introduce yourself. I've given you numbers, then introduce yourself, then start. Thanks.
Thank you, Chair. My name is Betike Hakilwe from ANC. Let me appreciate the report presented by the DG as well as the CFO. But my main concern as new members, find there is a plan, but we don't see any base. There is no baseline. We only see the targets. But for new members like us, it was going to be more helpful if there was any baseline for us to compare and to can have a proper input with regard to the plan. And then regarding the other thing, the life expectancy, the DG has reported that it has increased to 66.6, but as to from where, we don't know. Unless if the DG could have said it has increased by this percentage. And then, when it comes to the issue of TB, the success rate, Chair, is just for us to shine. But what is important, because TB is curable, we need to see the cure rate, not the success rate where you combine the cure and those who have completed the treatment. But we have the guidelines to be followed so that we know that our officials, our nurses and doctors, they do what it's supposed to be done. We can have a success rate of 83, only to find 0 of them was cured. They've just completed their treatment without a proof that they were cured. When it comes to the issue, the reductions, especially when it comes to, now to the CFO, when it comes to the issue, employee compensations, your presentation indicated that there is a reduction. But still we do have understaff in most of the facilities. That is why most of our services are so poorly provided. The nurses and the doctors, they are so burnt out because of work overload. So maybe if you can consider or give us the reason why the reduction, whereas we've got that shortage of staffing. That is my input. Thank you, Chair.
Thank you, Chairperson. Philip van Staren, Freedom Front Plus. Thank you very much for this beautiful, comprehensive report. I think if we can continue this path for the next 5 years, it will be very nice. Thank you very much. Chairperson, we've been sitting in this committee for the past 5 years, and we have experienced many problems with the department, whether it's the shortfall of doctors and nurses and medical equipment and beds and all that stuff. And we have done various oversight visits to various institutions in the country, but we haven't finished all of it, and I want to plead that we continue to do that oversight at hospitals and clinics. But we must start to keep the provinces to account to come to this committee. Excuse me. I think the last the past term, we start seeing some of these provinces just before the COVID gets to us, and then we haven't seen them again. So I want to plead to you, Chairperson, and to the rest of the members of the committee, that the provinces must come and take an account, and to come and account to us, to what we are doing with the grants they're receiving. They are receiving huge sums of money. And the complaints we are receiving from the public, from ground level, according to hospitals and clinics and so forth, we don't have it seems like they don't use the money, they have to spend it in a manner which they must do it according to law, and they don't spend it on the correct places. So that's my first plea on the oversight, the provinces. And my other point I want to make, we are here as public representatives. The department is always in meetings with us. We must hold each other accountable, because it's not our money, it's the public's money. And I would like to see that in this coming term, in this past, if this term is over in 5 years' time, we must be able to stand up and say we have eradicated all these problems which is facing our hospitals and clinics and doctors and nurses and everything. We had many discussions and many fights about it in the last term. I think I had to bring it up today because it's our first meeting. And so if we're going to do our job, let's do it in the correct way, correct manner, and let's hold each other accountable. The medical legal claims is also a huge problem. That needs urgent attention. But it won't be solved unless the problem on the ground level in the hospital and clinic is not solved. For now, Chairperson, I will stand with that. Thank you.
Thanks, Comrade Chair. And let me also appreciate the report that was delivered by the DG and the CFO. CFO, we are safe. I'm not good with numbers. I will also comment. I will comment on the report here, Comrade Schenk. Comrade DG, he mentioned that they are under non-communicable diseases. You mentioned the lifestyle conditions, and one of them being the cardiovascular problems. I've realized, I'm a new member, I've never been to this outreach and whatever that the comrade have been doing previously, but I've realized that with this...
Okay, sorry, Pete. I would not like to give the title of these members as comrades, and I know you are my comrade, and also would want to say maybe here we would use it in another platform, so it becomes a meeting where we would just be Honorable Tembekwaya, Honorable Van Staden, Honorable Skosana. Yeah, we leave it at that. I don't know whether they are comrades. If they are, but we don't address them as comrades here now. Thanks. Just that correction,
my apology, Chair. You know, it's always here. By the way, I'm Comrade Fisani. I'm Honorable Fisani Shabangu, representing the ANC. I'm from Mpumalanga province. This thing of comrade is going to be a problem. But anyway, I wanted to talk with under these non-communicable diseases. You see, when it comes to cancer and whatever, there is a noise outside. Something is happening somewhere when you look into the infrastructure. It's health. But under cardiovascular, one is concerned that with all the improvement with the infrastructure, that area is not given the attention it deserves. When you look into our communities, the poor communities, black in majority, in our language, there is no heart attack. We talk sharp pains, all that. But we've realized with the new lifestyles, heart problems, heart diseases are real. But when you look into these so-called district and academic hospitals, when we refurbish, we do not take consideration of that the community must get that service. It's not getting the attention it deserves. Take, for instance, Nelspruit and Gauteng. You travel 5 to 6 hours. If you happen to be in a hospital and you get a good doctor that will be able to diagnose you that you have a heart attack. If you think of a door to nickel, period, we are not doing justice to our own communities. And I was looking at this presentation and I'm somewhere trying to check. I don't know whether when we upgrade our infrastructures, whether there is lack of skills, human skills to deal with this. Because a person will travel 6 hours. Yes, there is a private hospital nearby. I don't know whether the NHI will help us in that, which I'm not sure whether I will be able to unpack it if I'm expected to unpack it as a member of this committee. But I think I wanted to raise that to the presentation that was presented by the DG. That area, it's not getting the attention it deserves. With the upgrading of infrastructure and whatever. That is why I'm saying that with cancer, at least you can hear somewhere, somehow is being tried. But when it comes to cardiovascular, our people are dying from those conditions because there is no help. Sometimes you lie in your local hospital because there's no space in Pretoria or Gauteng until you really have heart problems. Thanks, Comrade Chair. Oh,
practice slowly.
My apology. Okay.
Practice slowly to get out of it for these meetings. Honourable Honourable Clerk, for now. Yeah.
Thank you, Chairperson. I have to concur with Member van Staden. You know, we've not had the provinces come here to come and account, and I think it's something that we really, really need to look at. And when I look at the allocations in terms of the grants given to provinces, it would be very interesting to know what their accruals are and what their legal claims are against their budget, because obviously that is deducted off their budget before they can continue operating in terms of their hospitals. So that would be very interesting. And yes, it would be good to see a baseline. I must concur with that, because we can see where we're at and what we want to achieve. This report doesn't give us that information, and I want to see that information where we're at. I mean, particularly when we talk about electronic patient systems. I mean, we all know that that is not doing well at the moment. I mean, I go to lots and lots of hospitals, and they're still not on par with what we want them to be on in terms of what the NHI bill requires them to do. So, you know, those kind of things we'd really like to have baselines to see how we're doing and what we need to do in order to fix the issue. Also, in terms of mental health, I am very concerned, Chairperson, when I visit hospitals and I see the status quo of mental health patients and the treatment that is available, because you find that, you know, hospitals keep them for 72 hours and they need to place them into a facility. Normally the facilities are all full, and you find that patients suffering from mental health ailments are put into a room or put into casualty, for example, and they lie there for weeks on end. And that is something that really concerns me when I visit hospitals, because you see that firsthand. So that is something that I think we need to really address very seriously. Then also, in here it says sustained reduction on maternal and infant mortalities. Now, last term I asked some questions around this, and I can't remember the figures offhand because I don't have that question with me. But it didn't tell us a good picture. It really didn't, and that is something that really needs to be dealt with in terms of that. And then in terms of our facilities, and I note the budget. You know, in terms of our facilities, that we're building new hospitals and that we're upgrading our hospitals, etc. But I think that there's a real need to look at, and I'll just use example like Dora and Giza. I mean, half of that hospital has not even been utilized, you know, when we did the oversight there. So, you know, to build lots of new hospitals, yes, we do need facilities, but I think there's a real need to look at a lot of our hospitals where there's lots of space that we can actually fix and upgrade that space and utilize that space. Because when we've done oversight in the Eastern Cape, we actually came across many hospitals that actually have a lot of space where we can upgrade those facilities. And yeah, I'm very happy to hear that we're upgrading facilities, because I find it very troublesome when I go and do an oversight and I see an ENT specialist having to operate with a cell phone light. You know, that kind of thing is, and that's why I am very set on the provinces coming here and presenting their plans to us so that we can do proper oversight over all provinces. Thank you, Chairperson.
Next one is Honourable Low. Hello.
Yes, LaRue, thank you, Chair. Thank you to the DG and the CFO for your presentations. I have a few questions, some to the DG and some to the CFO. Just looking at the strategic overview, and well, let's just start with the budget. We've seen that there's been a massive increase in medical legal costs from all the provinces. There's massive litigation in all the provinces of the country at the moment on case of negligence. There doesn't seem to be any consideration for that in the budget. I see there's about 5 million allocated to committee and to medical legal committees, but very little else, no money set aside for that. So I just want to check if there is anything. Have I misread that? But that's obviously a major cost, and I know in some of the provinces that comes out of the patient care, which is obviously massively harmful to the poor who don't then get the care that they require. The second question I had was just around to the DG around the indicators. I saw the very, very ambitious 95, 95, 95 HIV sort of goals. How are we measuring those? Because I think it's easy to aim to say that, but to actually, how do we know that 95% of patients who are HIV positive are actually being tested for HIV? How do we know that 95% of them are on ARVs and that 95% of them are actually virally suppressed? So what indicators are we using to do that? It wasn't clear for the presentation over there. Third point on TB, we're talking again about big goals in terms of improving the cure rates of TB, but there was very little about TB preventative care. And we are continuing in a model where we are focusing on curative care rather than preventative care. I'm thinking about the new policies along TB preventative treatment, and also for doing household contact tracing or finding TB cases. What are the plans there, and how are we planning to do that as part of your strategic plan and your performance plan? And then back to the CFO in terms of questions around budget. I see there's been a reduction in for staff in this budget, and that's obviously makes a massive impact on how we provide care to patients, and it stands against the basic principle of improving healthcare to also. So what was the reason for that? And I see the whole budget has increased, but specifically for compensation of staff, that's gone down. And then the final one was, again, this very ambitious target to pay all valid invoices within 30 days. Again, that's a laudable audit, but a laudable aim. But I know there are lots of provinces who are on massive debt and in arrears for not just 30 days, but for 6 months or sometimes more than that. How are we going to be able to get rid of those shortfalls and move forward from them? Thank you very much.
Honourable Letlhape.
Thank you, Chair. Just as a new member, it might have been helpful to have had the presentation before so that we could go through it. I know that we didn't exist as a committee, but I hope that going forward we'd be able to get the presentations before they are presented here so that we could look at them and maybe even start asking some questions before we meet. And something that is conspicuously absent in the report, maybe it was done in the previous period, is something about COVID-19. Since we've just come out of COVID-19 with devastating consequences to our health system, and there were strategic decisions that were taken about closure of schools, vaccine programs, wasted vaccines that were not used, national immunity, contact tracing, I think it's an important thing that we would hope the department would report on so that we're prepared for next time. And that as the international health regulations are revised, we are alerted by the department as to whether we are prepared for those changes and that as a nation would be fit for purpose. I also have a question just in terms of the NHLS was mentioned in the report, and we've had a security breach at the NHLS, which has a devastating impact on patient care. Just in terms of what is being done in that regard, in terms of preparedness going forward, given the restrictions of the PFMA in terms of ransomware, and whether what have we learned and what are we going to do to ensure that our systems are more resilient, particularly on the recovery side, because the attacks will continue to occur going forward. It's about our preparedness to deal with those. There's an issue that has been put through by both the DG and the CFO about invoices paid within 30 days. And that's remarkable. But where the rubber hits the road, does that occur? When you pass on money to provinces, do you measure how they perform in that regard? I sit in a province where the third largest hospital in the world was not paying its telephone accounts. So Barra's phones were cut with disruption to services. They can't have been cut for not paying on 32 days. So how do we measure that at a provincial level? Because that's where the interface and service delivery occurs. There'll be other issues that we would engage with going forward. For example, accreditation for providers. Are you accrediting them or are you contracting with them? Is it contracting for providers? So that there should be clarity about how you interface with the other statutory bodies that are accredited. Because if that function is taken over, as a practicing doctor, it would save us fees to the HPCSA if the department has taken over accrediting professionals. TB. Just to link to what the honorable member was talking about, what are we doing about prevention? Because I have the sense that in South Africa, we have habitats that are great incubators for a disease like TB, where overcrowding is the norm. We have informal settlements, no ventilation, people living on top of each other. Do we treat them, take them back to those habitats and hope we'll be able to eradicate TB? How do we interface with other departments on those issues? Lifestyle diseases. That's about personal decisions that you make. Do we factor in environmental factors, governance issues, societal factors that influence lifestyles? I mean, I grew up in the township and we had lots of sports fields. So as we grew up, when our parents were working, we could occupy ourselves with playing soccer. You go to Soweto now, there are no open fields. And the kids are in the street doing drugs. Those spatial arrangements in terms of things that have a health impact that are influenced not just by lifestyle, but also by the environment that we live in. And a question that might be of a personal nature, the issue of GBV and femicide, is there a health lens to it? And if so, where and how do we look at that? A question that has come up from the House has been about accountability of provinces, how we can do oversight, access to facilities at a local level. When you go back home, can you go to a clinic? How do you do that? And a lot of members have been reporting being refused entry to health facilities. How can we deal with that aspect? The issue about drug distribution, the medicine parcels, PUPs, is it an outsourced program or is it insourced? Because I'm just concerned about our inability to rebuild public service, where instead of rebuilding services, we outsource them. I mean, in Gauteng, instead of rebuilding oncology services, they want to outsource them at twice the cost from the private sector when we should be rebuilding our issues. Has an assessment been done about the impact of non-compliance? I mean, we have a few old ladies in our family, and some of them are stockpiling medicines. Because they have them, there's no advice, they decide what they're going to use, what they're not going to use, and they end up stockpiling medicines. Is there something that is being done to look at the issue of compliance, utilization, and recovery of medicines that have not been used? The Fiscal Commission spoke to us, and as a new member, they're talking about, are we spending our money in the right places? Has there been a discussion between Health and the Fiscal Commission as to, are we spending our money in appropriate places, or can we do better? The issue of litigation as a rising cost. Is there a plan of action in terms of how we're going to deal with that aspect? Because there's low-hanging fruit in terms of what can be done. No fault compensation. The issue of, if you came to a public healthcare system for your care, if you have an unfavorable outcome, your future care would still be with the public healthcare system. So why should there be a large payout in court for future healthcare costs? Issues like that, looking at legislation around that issue, because it's becoming a rising cost going forward. RWAPs, destroying the training platform, where people take full-time salaries and run full-time practices. Isn't about time that we make a decision? Because the people that will tell you that if you take away RWAPs, they are going to leave. They've already left. You're just paying them. They're basically like glorified ghost workers. And that issue, I hope, will be dealt with as a health emergency that it is. The IT platform. If you look at our expenditure post-94 on IT and information systems at province level, etc., we spend an inordinate amount. Can we come up with a coherent national plan that will be for all health encounters? Not that Gauteng has its own little scheme in its clinics, KwaZulu-Natal has it. I mean, we're the same people. If you have an ID and a smart card, we can make sure that things are centralized and the department leads. Second last thing, on lifestyle, things that are related to behavior. Are there any plans to balance the pharmaceutical model with the model of improving people's behavior? We're doing the right thing. We're providing PEP. We're providing PrEP. But HIV is a sexually transmitted disease. What are we doing about preventing new infections? Not just reliant on pharmaceutical products. So for me, the last issue is oversight. As the Director General and the CFO said, you get lots of money, but most of it you pass on. How do you keep those that you pass the money to accountable? When we're talking about maintenance at a national level, does that truncate to how it should be done at the front line? Are we going back to having maintenance department in hospitals? When a tap is leaking in a hospital or in a clinic, where do we go, Chair, for that? Isn't it time that we begin discussing health being a national competence? I thank you, Chair.
Welcome, Minister Mtsoaledi. I welcome the enthusiasm of Honorable Dr. Letlape. I noted 11 of your comments coming through. Half of those the Minister was getting into, so he probably will come whenever he wishes on those 5. Not on the ones, Minister, you don't know. The fortunate member was also going to listen is the last member. Honorable Dr. Thembekwayo, it's your last, is the last member to input. Thank you.
Thank you very much. Greetings, our Minister. And thanks for the presentation then. My starting point is based on the induction that we had last week, where the theme for the seventh Parliament is transformation, which obviously means transformation should take place in all departments included. That's what I think, which means we can't go on a repeat of doing what we were doing in the sixth Parliament, the same, and expect us to say we have transformed within the department. It can't be like that. And most important, that within the principles that were mentioned there was the maintenance of public interest. And I'm just going to apply and raise a question on the slides on page 4 as compared to page 6, where in page 4 there is under key focus areas for 2024-2025 accepted that community engagements to promote participation and aid responsiveness to health needs. Yet on page 2, under program 1 for administration, you have health promotions and community participation, number of community engagements on health programs allows it to. I think we have to relook on that. If we want a proper participation of communities, then it can't be true. It can't be 2. It has to be a better number, but it has to be improved from 2 to something else. And still on the same page where we talk about the employment equity targets, for transformation's sake, we can't be happy and accept that only 2.5% is the one that is given for people living with disabilities. I think we have to change, because 50 is women, 30 is youth. Why is it 2.5% only for the people living with disabilities? For the transformation, can't we up the percentage for the people living with disabilities, taking into consideration a number of the people who are disabled in South Africa vis-a-vis the percentage that we would like to use on the thing. The second question is based on the alleged bid rigging that was mentioned in January 2023 in the 486 million lease for the department's new office. We need an update on that, even though we know that it's an investigation based on the court, but you can take us into confidence and just tell us on the proceedings at the present moment as they are pertaining to this matter. Very important, when you go out on oversights, whether it be an oversight in the province, whether it be an oversight in an unfortunate incident of a hospital, say the hospital has burned, and so on and so on. Like I'm saying on transformation, how are we going to, say for an example, we went and we meet with the minister's department. We say to them, this is the situation. How are we going to work together in improving whatever the unforeseen circumstances can be derived from the oversight that we could have done as a committee, so that we don't only go on an oversight, we have our own recommendations, but the recommendations does not speak or are not addressed by the department itself. Because we also, when we go on oversight, we also have representative from your office. And then how are we going to go about addressing such issues? The following one is about the, following the assassination of Babita Dekran. The one is an unfortunate occurrence. We usually ask to say, How is your department protecting the whistleblowers in health sector? It's not clear enough and explicit enough on the plans and the projects that are in place to protect the whistleblowers. How do we plan to close gaps for corruption practices? There are a lot of corruption practices that are happening. How do we plan to close that so that we move on a clean plate? If something is reported, if a corrupt or a corruption matter is reported, how do we conclude it in such a manner that all of us are satisfied with the outcome thereof? And lastly, how do you intend to address the committee recommendations on the findings arrived at from oversight, including the recommendations from the Auditor General? We usually have negative results or reports from the Auditor General, but each and every year there occur the same mistakes and nothing is being done. And especially when we find that the mistakes that are done by the department itself, I mean the National Department of Health, having some negative information that are derived from the Auditor General. We have to do things differently in this period, for this fifth-year period. And please, can you be able to update us on that? That was the last question, Chairperson. Thank you.
Thank you very much. May I also add, you do allow chairpersons to also add in the bag of questions. Maybe let me take in from where Dr. Thembekwayo has left off. There was a report of the oversight visit of this committee to the Eastern Cape Department of Health. It even served in the House. I don't know the processes of getting that being attended to. But just for our sake, I would request that if that report can just be given to the new members, because linked to that has been about 4 members mentioning that would like to do oversight to provinces. Now, we don't ask anyone to do that. You just make a plan. So it will be within our own arrangement. The province that I remember the committee visited very well was the Eastern Cape, and the report that you brought back from the Eastern Cape merited a tabling in the House, and it was part of a debate in there because there were certain concerns therein. So I would really want to say it is within our own decision to visit provinces as oversight. We would actually inform the minister, get his support to go there, but not that we need to really make a special request that we want, because we are citizens of the country. We do pick up challenges here and there, and therefore, as part of oversight, we should therefore make that plan. I'm raising this because I think 3 other members have raised the same point of oversight visits to provinces. My other comment on page 3, but let me commend the department firstly for we are one of the few departments who actually bring a presentation with number 1, 2, 3, 4. It's easy for us to make reference to say, can we look at slide number 10 or whatever, because you are actually numbering. Now, slide number 3, you are talking there about the 10 pillar of the Presidential Health Compact. You would recall, I've always been commenting, and I will always continue to say, the 9 other pillars are supposed to be really the hymn song of the department, because those are our enablers of not only just universal health coverage, but of the health system strengthening. I was listening to the minister this morning on the TV mentioning all of the 10, and he was picking up on these 9 pillars to say, talking about leadership, finance management, infrastructure. Now, we would like, because that is your plan of really taking us into the new, better world of universal health coverage. Let's hear you talking about it. Let's see it being done continuously. And there's been a first health compact 2018. Last year there was another one. again to look at how far. That is when you added this 10th pillar. Now, let us not really wait. Let's hear you to say, today we are just sitting at the Department of Health to evaluate ourselves and tell the country where are we with the 9 pillars, now 10. Please, let's do that, because that is one other way of adding confidence to the South Africans that what you have put in as a plan going forward will actually do work, and then we'll be very happy about that. I want to also join my honorable members when they're saying your report, Shenge, did not have a baseline. On slide number, I think 7, you are talking about wanting to improve on the CCMDD to 9.5 million. We don't know what's your number, what's your baseline, what is what you had last year. So we want to go to 9.5, coming in from what figures? There was once upon a time 1 patient, 2 patients, 3 patients. So it would be important to say right now we are really going for 9.5 because last year we ended at about 7 million or whatever number. So with all other members mentioning that it's difficult to really talk about we are going to 9.5, but where to come from in terms of your previous performance. Now, I was listening to you very carefully, DG, and the words you used, electronic medical records, very soon. I was not impressed with very soon, because very soon is as good as very long, very short. Now, I don't know what is your very soon. If you could really assist us to quantify this very soon, even if you are not truthful, hopefully you will be truthful. Just give us some sense of confidence as to where are we going with this process. One is aware that we are underplaying your successes on HPV, and it's a very important program that we need to talk about, and let's hear more about certain things that we have done on these issues. Let me just see on the last one. It would be important in your slides and some of your efforts. Honorable Dr. Letlape talks about TB prevention. And if you do not up your game, and I know you are trying, in terms of TB in the mines, because that's where sometimes you find a TB mine worker who actually goes home undiagnosed, and the TB that he has picked up in Rustenburg goes to Lusikisik. And therefore, the whole community that otherwise they never had TB has received TB. So we would also want to say that TB in the mines should also be coming in. Probably it was assumed it is part of your story, but we do not really get that part of it very well strongly. The last one from my side. The 5x5, I will always shout it even though one is not in that space anymore. You see, 40 years ago, there was a professor who used to teach and say, if you want to look for hypertension, diabetes, in Durban, we must go to Chatsworth or Durban North, because that's where there was a community of white community and an Indian community. Now, 40 years down the line, epidemiology tells you if you're looking for hypertension, diabetes in Durban, it doesn't matter whether you go to Durban or Wamash, the same place has got the same. So it means we are actually getting to a space where non-NCDs, hypertension, diabetes, are going to be a new pandemic under our face. We really appreciate your strides on issues on TB, HIV, and continue with that. But we just don't think, and I also have been saying it while I was there, that I don't think as a department we are pulling all the efforts in pushing for NCD to be our new pandemic that we say this is going to be hitting us very much so, and we need to do something about that. So we will give you comments, space to then reply to us. Colleagues, just to remember, we should be wrapping up the latest 10 to 3 in this hall so that we leave, allowing other meetings to take place. Back to you, DG, and your team. Minister also. Sorry, okay, ma'am.
Thank you, Chair, and my apology for speaking after you. I've forgotten to raise this issue of the allocation of funds to the provinces. Looking at the presentation done by the CFO, provinces like Limpopo, Mpumalanga, Northwest, and Northern Cape, they've been allocated a smallanyana amount, but those provinces are the one in need of health services. They are scattered. Some they will go for a month without a mobile clinic, let alone a physical structure. So my appeal is to reconsider the allocation of funds to the smallanyana provinces. Thank you, Chair.
Thank you very much, Honorable Chair and Honorable Members, and greetings to my Minister. I've got a team that's supporting me. I'll start with, from planning, I would like Kokeso to deal with the issues of the baseline. Also talk about the annual report, which is still to be tabled in this committee in September. That will give most of the information of the performance in the previous year, including the audit, and all the issues around the indicators. Kokeso, you will deal with that one. When Kokeso is done, I'll request the CFO. CFO is going to deal with all the finance-related matters, allocation, the audit, how do we monitor, how do we implement the audit findings in terms of the audit plans, and all finance-related. When he's done, then I'll request Professor Crisp specifically to deal with there's a number of issues around CCMDD that came up, but I'd also like him to talk a bit about the Health Sector Anti-Corruption Forum that he participates in terms of fraud management within the health sector, not only in government but also in the private sector. I'd also like him to talk about COVID, the number of issues as he led that program in the department. There's quite a number of questions that came from the honorable members that I'd like him to touch on. I think, and then I also talk about digital health, information systems, electronic medical record, and then I'll take all the others before my minister comes in. Thank you very much. Over to you, Koketo. We have a very limited time.
Thanks, DG, and thanks to the honorable members for the valuable inputs. In terms of the comment around the baseline, we have noted that going forward in terms of also highlighting for the honorable members to be able to make a comparison. Just in terms of touching on the three that were mentioned of interest, in terms of life expectancy, it was, before COVID, it was 65.4. And it took a knock during COVID, and now we have improved. It took a knock to 59.2, and now we have improved to 62.8. And the one on the CCMDD, we are currently sitting on 9 million parcels that have been distributed to the pickup points, and we are going to therefore ensure that we accelerate that to 9.5 million. In terms of the employment equity targets, we are guided by the targets that have been provided by the Department of Youth, Women and Children. People with disabilities, as far as the aspirational targets for 2030 in line with the NDP. So we are working progressively towards those targets. So on a year-to-year basis, we do look in terms of how we have managed to work on those targets and see how we can improve towards the 2030 targets. Thanks, DG.
Thanks, CFO.
Thanks, DG. I will really appreciate the comments that we received. So I will also provide the clarity on some of the questions. There was a question relating to why the budget has been decreased in terms of the COE at the National Department. So when we received the budget allocation from Treasury, they did indicate how much has been allocated. And based on the allocation in the current year, it was less than the allocation that we had in the previous year. So in the allocation letter, Treasury, they will say is the total amount of so much, which is the amount that I've indicated. is specifically and exclusively appropriated, which it means from Treasury point of view, that money cannot be increased without the approval of the National Treasury. So then it means as a department, we cannot spend in terms of the compensation above the money that has been allocated by the Treasury. So that is the reason why that money has been decreased. So in terms of the comments from the honorable members, the money of 15.9 million that has been decreased in the COE, that money is only for the staff at the national office, which is to support the programs which the DG has presented earlier. So it does not include the appointment of staff in the facilities, which is the doctors and nurses. So now when it goes back to also the question relating to the budget, in terms of the baseline, but my colleagues have already indicated the issue of the baselines. So in terms of the allocation of the budget, maybe just to briefly, Honorable Chair, just for a second. In the previous financial year, we had 60.1 billion allocated, which is the last financial year. Then during the adjustment, then the department, they've suffered a reduction from National Treasury of 1.5 billion, which a billion was coming from HIV and AIDS, and 440 from the Revite, and also 205 million from the National Department in terms of the allocation from the voted funds and the allocation to the other entities and NGOs. Then in terms of the indicative figure, how much we then were supposed to get in this current financial year, in terms of the documents, it was 62.4 billion. That's how much we were supposed to receive. So based on then the revised allocation from National Treasury coming to the current financial year with the actual allocation of 62.2 billion, and therefore hence we indicated the overall reduction of the budget in the department with 225 million. So that is the reason, but in terms of the details, it will follow what the Gogetso has said in terms of not showing the baseline, but all that information is, I think it will be available. And also the comment in terms of the allocation of funds to the provinces in terms of the conditional grant, because the money that we allocated to the province, it's not the all money that the provinces they have in terms of provision of healthcare services in the provinces. So the total allocation for the sector, when you compare with, or when you take into account the allocation to all provinces, is about 259 billion. So that includes the 56 billion which I have indicated or we have presented in this committee. So then the other funds which are available in the provinces, then they use in terms of the provision of the services in the provinces. So in terms of the other relating to monitoring of the provinces, more especially on the conditional grants, is based on what the DG has said, that there is a framework where the provinces, they will do the business plans which they have been approved by the DG. Therefore, as a unit, we have the responsibility to do the monitoring of the spending in terms of the agreed business plans, to make sure that the provinces, they spend in terms of that agreed business plans. And also the provinces, they will draft the annual procurement plan specifically for the conditional grants, but then they will have the separate one for other sources of funding. We do the provincial visits, we do the quarterly reviews in the provinces in terms of the spending for the conditional grants. It also talks to the issue of the audits. How do we monitor? We do have the CFOs forum where we sit with all the CFOs from the provinces, where they also compile all the audit action plans. We go through the plans. We do assist the provinces, even in terms of the technical issues that they will have with the AG, where we have also established the 3x3 with the AG, where we come together and discuss some of the technical issues which the provinces then they do suffer during some of the processes. I think the issue of the medical legal, maybe DG will also be able to elaborate more. I think the other questions then they were actually the same, which I've cleared. Thanks, DG. Oh, no, thanks. DG has just reminded me the issue of invoices, because I did not indicate it here. In terms of the invoices which the honorable members they've asked, I can indicate, Honorable Chair, to say in the department currently, the payment of invoices to service providers is less than 10 days on average. But however, we will have some of the instances where then the suppliers, they are paid over 30 days. Those becomes where either we still reviewing the invoices, or sometimes we'll find the invoice, it doesn't tally with the order, or maybe there are issues with the banking details and so on. So in the current financial year, the reason why we had a number of invoices which were paid after 30 days, so they were relating to medico-legal, that the national department was supporting the provinces in terms of dealing with some of the medico-legal claims. So some of those invoices which then the national department was paying in terms of the provinces, that's where there was a number of invoices which were paid within, after 30 days. Thanks, DG. Thanks, Chair.
Yes. No, thank you very much. But also just to mention that the zero is referring to the National Department of Health. But also just mention that the provinces have their own APPs that they also put into the provincial legislatures with their own provincial targets on how they deal with matters. May I request Professor Chris to come in?
Thanks, DG. And good afternoon again, Honourable Chair, Honourable Members and Honourable Minister, colleagues. So the DG asked me to address a number of the issues. So I'll start off with the medical legal issues. There's a health sector anti-corruption forum that's working hand in hand with the National Department, and the National Department has a working group together with the provinces working on medical legal issues. So what it would be useful for honourable members to know is that a large proportion, we don't know the actual percentage yet, but a large proportion of medical legal claims are absolute fraud. And at the last meeting of the Anti-Corruption Forum on the 28th of June, which I attend, we went into great length dealing just with the medical legal investigations. And there are literally hundreds of lawyers who have been reported for fraud. There are at least 70 people who have been charged with criminal charges in terms of Section 17(2) of the Health Act for being illegally in possession of patients' records, and there are over 3.5 billion rand. We'll put out a formal report of monies that have been prevented from being spent because of the interventions of this forum, particularly the SIU and the NPA. There are other actions still going on at the moment. So just in terms of the medical legal controls, that's one of the actions. There's also, as I said, an activity going on between the National Department and the provinces on monitoring medical legal claims. Because what happens is that claims are lodged in more than one province. A patient might be seen in a clinic in Mpumalanga and a hospital in Gauteng, and then they'll lodge a claim around that patient's condition, or sometimes there's not even a condition, and in some cases there wasn't even a patient. But they will be lodged by the lawyers in more than one place, and it's taken cooperation in the forum between the departments to try and uncover what is going on. There's a case management program that's happening there. Related to the medical legal cost, there's another issue which was raised by honourable members about where we pay, and I think it was Honourable Letlapi who asked about the litigation and no-fault compensation and so forth. There's a review of a number of pieces of legislation that's been underway for a while. The one is the State Liability Act, where the Departments of Health have been pushing to get an amendment to the State Liability Act so that the provinces are not going to pay upfront for instance, 30 million rand, and then the money sits in a lawyer's account and 8,000 rand a month gets paid out to the patient. So we've been fighting that, and there was a case won in the Eastern Cape, which has now set precedent, which shows that we do not have to pay it all up front on the contingent liability space. But that's not finalized. There's not been an amendment yet to the State Liabilities Act, and we continue to interact with the Department of Justice on that process. There's also a review that's been going on from the Law Reform Commission into the way in which all legal cases are happened in the health sector, and not just the public sector, public and private sector. And so the issue of no-fault compensation is raised in that report. It's a very substantial report. The Law Reform Commission does not like no-fault compensations, and they have a range of other options that they are looking at. We've had meetings with the Law Reform Commission as the department, and there's ongoing work with them. But these reforms have far-reaching implications into many pieces of legislation, so it's not going to be finalized in a short space of time. The last issue related to the medical legal, and I think the Honourable Themba Kwayo asked about whistleblowers and so forth. There's a project recently being concluded together with UNODC, that's United Nations Office of Drugs and Crime, who are working with us. This program looks specifically at how to deal with a whistleblower program and with the management of reporting of crime and corruption that goes on within the health sector, particularly in the public sector, but also in the private sector. That program report, as far as I know, is concluded, and there was a discussion at the Anti-Corruption Forum on the 28th of June about rolling out further to other provinces based on what was learnt in the Free State. And there's also a meeting tomorrow where we will be meeting again, where the UNODC is going to provide some support to us in setting up our framework for anti-corruption and fraud prevention in the National Health Insurance. There's quite a lot of work going on in that space. I think that covers all the medical legal questions. The second set of questions are around the electronic medical record. So where we are at the moment is we have what's called the minimum viable product of the first phase, or the first module, if you like, of the electronic medical record is finished. It is under field testing in the Free State at the moment, and we have presented it. We've done a video presentation to the National Health Council to show them what's in it. It concentrates on the HIV and TB data collection in this first module, mostly because there are a lot of parallel systems that are largely donor-driven that are causing great difficulties for us to collect data in that space. And it's very difficult to manage a patient with HIV or TB who also gets pregnant and then gets other illnesses because their data is captured in these vertical silos. But the second phase will deal more with what we learned during COVID and vaccinations, the EBDS work that was built onto the NHI's database, and we've already had interactions with the Child and Health part of the National Department of Health that we want to start preparing for the next phase. So we're hoping that by November we'll be ready to roll out this first November this year, I'm talking about. The first phase testing, which we're busy with at the moment, will be ready for rollout, at least in one site in each of the 9 provinces. That work is happening. It will not address, just to moderate expectations, it will not address all the backlog hospital records. It will not address all hospital records in all hospitals in one space of time. You can imagine that is really expensive, and it will not replace all the existing health records that are captured in the provinces. What it will do is create the common record that we will all use going forward once we are registered on the HPRS, and each have, that's the Health Patient Registration System, and each have that unique identifier. Then when you go to any accredited provider, the provider will open your file using your own ID and your own fingerprint to get into that record to continue your care. So it's a long project. It's very big. It's got a lot of developers working on it at the moment, and we only have enough money to do it in pieces. Related to that, I think, is the question of the accreditation of providers that Dr. Letlape asked. So we must make a distinction between different words. The Office of Health Standards Compliance is responsible for certification of standards in providers. The professional councils are responsible for registering professionals and making sure that they remain registered, current and safe in their practices. None of that changes. Accreditation is where the fund finds that a provider is both compliant, their individual providers inside the establishments are registered, and then that they comply with the benefits package, the formulary, the digital systems, etc., before they are allowed to contract with the fund for public money to be paid to them. So we are very happy that we're working with all the different players. There's no duplication of any of the systems, and the way the system is designed is to go and, if you like, we talk about pinging. It goes and it looks for the provider on the provider registry, whether it's the Nursing Council or the HPCA or wherever. So we can come back on a subsequent presentation and give you feedback on what that's about. Okay, the next issue that was DG asked me to talk about is COVID-19. So today we didn't speak about COVID-19 because this is the plan going forward. But I guess what Dr. Letlapi really was at was, what happens if there's another pandemic? What did we learn and what are we doing about it? And there are a number of issues which are in the plan, but they weren't specifically addressed, Chair. For instance, we have a program going on antimicrobial resistance, and there's a One Health program that's been driven globally that we are part of. We are working together with a number of other departments, especially Environmental Affairs and Agriculture, because antimicrobial resistance is not a massive problem in humans at the moment in South Africa, but it's a very big problem in the Agriculture Department, where antibiotics are freely available and put into feedlots and so on. So that program is a global program, and we are part of the Africa program and of the global program. Also related to what we learned during COVID is what we are doing with vaccines and other products, but mostly vaccines. And there's a collaborative in Africa to improve our capabilities for developing and manufacturing vaccines for Africa in Africa. And South Africa is a big player there because of Afrigen in the Cape, BioVac, which has got it's a partly government-owned facility, which has a lot of capabilities. So the networking that is going on is very significant, but there are global players that we have to take into consideration. And yeah, so we take part in the United Nations processes related to international body for negotiating in that space. I think the last one I was asked to talk about is the CCMDD. There were a number of questions related to this. So the way in which it works at the moment is that the chronic centralized medicines program was originally developed as a donor-funded program for HIV and TB to get antiretrovirals distributed to patients who are already stabilized, but to distribute them outside of health facilities, so decongest clinics and outpatient departments. It has outstripped its initial value, as I think was presented, which there are chronic medicines that are being distributed as well as other chronic medicines as well as antiretrovirals now. The problem is that the program grew so fast that it is not fully funded all the time. And so we have had a program running for the last 12 months, trying to understand exactly what the line of development can and can't be. And there are moving parts. For instance, shifting scripts from 1 month to 3 months and from 3 months to 6 months and so on have impacts both for the patient and for the facilities and for ordering of medicines and for distribution. At the moment, the distribution network is on contract. The price has been brought down dramatically by reducing by renegotiating the contract on multiple month dispensing, and there are pickup points that are both in facility and out of facility. And the pickup point, whether it's at a small shop or whether it's at outside a pharmacy or whatever, they get paid, but the ones that are in public facilities obviously don't get paid. Now, not all, there was also a question about baseline. So the baseline, that what we've done is we've shifted the target now not to the numbers of people, because every year we were just saying, this is the total number of people who've been registered. And that doesn't help because people leave, people die, new people come on, and so on. So what's more important is how many are actively on the system. And there are about 2.7 million people actively collecting medicines every month on the CCMDD program. So you can imagine the impact for those people. They collect parcels, and we monitor the numbers of parcels now, because some of them is not monthly anymore. It's now 3 monthly, or some 2 monthly, and there were during COVID 6 monthly. So we are trying to stabilize the number of parcels and where those parcels are collected, and we are monitoring the number of uncollected parcels. That goes to Dr. Letlapi's question about what do you do with unrecovered medicines. What we can't see is into the household of non-compliance, which is what you were asking. And that's a task which we would like to get community health workers to assist us with, because we're familiar with the challenges. So we're trying to reduce the unrecovered meds, and they can be redistributed. But once they've been opened by a patient or taken by a patient, it's illegal to recycle the medicines. So I think, I think DG, I've covered the questions you wanted me to.
No, thank you very much, colleagues. I'll be very quick to use modeling. In the country, we use the TEMISA model, working closely with the UCT. They give us these estimates, and then most of this data then gets triangulated, and then we're able to get the data. But we also have our own crude data from service delivery, which we collect through the DHIS, District Health Information Systems, so that we are able, and then working with all these institutions, they are able to triangulate this data at any given point in time. We know where we sit as a country as we move forward. I think on the mental health, I do agree with the honourable member. This is a problem. The actual outbreak of mental health illnesses is actually outstripping our capacity. For example, we get letters now and again from Justice Cameron, who heads the Judicial Inspectorate for Correctional Services, because of the people who are in prisons who should be in hospitals. But because of the shortage of beds, for example, we only have only 24 of those facilities that helps us in the country, 5 in KZN, 4 in Gauteng, 4 in Western Cape, 4 in the Eastern Cape, 1 in the Free State, nothing in Mpumalanga, 2 in the Northwest. So it's very difficult because now of this outbreak of mental health illnesses that we have. And then the honorable member from Mpumalanga, my apologies if I didn't get the name right, the issue of Mpumalanga, because Mpumalanga, in terms of tertiary services and central services, is purely serviced by Gauteng through Steve Biko Academic Hospital. But we've deliberately, the CFO was with me in the meeting, the MEC was there, we've deliberately put in money to build tertiary services in Mpumalanga, mainly in Witbank and what's the hospital in and Rob Ferreira. And we've increased the allocation for the national tertiary services. And one of those is linked to say they must develop their own oncology services. They must develop their own, the member spoke specifically about cardiovascular services. For example, would like to have a cardiac cath lab in either Rob Ferreira or Mpumalanga, so that we get those patients being treated. The other big issue that we have in Mpumalanga that remember is that we don't have a mental health facility at all in Mpumalanga. That's one of the major issues that we are deliberately moving the conditional grants. What's nice with the conditional grants, we're able to talk to National Treasury. We say, look, let's not spend all money in Gauteng because we'll keep on bringing people to Gauteng. Let's decentralize the money to Northern Cape, build services there, Mpumalanga, build services there, Northwest, build services there. We know with the Northwest, they're also suffering there in Gauteng, but we know that in Klerksdorp, they've got Tsepong that we are building, the Tsepong Hospital, that is so that they take away the pressure. So I have a lot, but I would like my minister, because of the time that we're given. Honorable Minister.
Thank you very much, Chairperson, and thank you for giving me this opportunity, even though I joined you very late because of cabinet commitment. When I arrived here, Honorable Dr. Letlapi was speaking, obviously. Those are the only questions I've had, but the others I picked them as you were answering. Dr. Letlapi, I'm very happy because you know this sector as much as I know it, and I'm sure we are going to work together to resolve some of the problems. Let me start with this issue of litigation. Medico-legal litigation is destroying the healthcare system of the country. And what people don't know, they believe is destroying the public sector. Actually, it's annihilating the private sector, even more than the public, and I'll tell you why. This is an American system, by the way. It's a very bad system. Dr. Margaret Chan, who was a former Director General of the World Organization before the present one, she asked me a question. She said, Dr. Mtswaledi, why in South Africa your healthcare system is British? It is British because we were colonized by the British. Our titles are British. The curriculum is British. The exam is British. Everything we're doing is British. And she then said, why are you doing that? But when you come to healthcare financing, you go American. You become American. And she said, the American system is the worst that America has ever bequeathed to the world. And part of what she was talking about is this litigation, whereby money which is supposed to be saving healthcare is actually making lawyers very rich. I know when I said this, the legal profession get extremely angry. There was a time when one of the, I don't know which Black Association of Lawyers was attacking me for saying this. This is a reality, and we need to work together to nip it in the bud, because we'll no longer have a health system in the country, both public and private, because of this. Dr. Crisp has already told you, I don't have the figure, but a very large number of this litigation that are there now as, what do you call the litigation where you don't pay the lawyer up front, contingency, yes. This issue of contingency, where you don't have to pay the lawyer, but you are going to share with the lawyer the money, what you get after litigating the doctor. That is the one that is also driving this thing. Because in terms of South African law, contingency is 25%. But believe you me, lawyers don't take 25% because people don't know. I'm sure you are aware that you meet this even in road accident fund, where a person is injured, is in a wheelchair, they go and get millions for that person, and the person gets paid only 10,000 rand. We know of cases where some of them even go to buy a cow and give to the lawyer and say, you have helped me. I've never seen this amount of money in my life, meaning maybe 50,000 rand when millions have been claimed. So the solution to this is no fault claim. which many developed countries have done. We are not denying the fact that mistakes do happen in hospital. We know that already. It has even been established by the World Organization. They say when you are in a plane, you are 300 times more safer than when you are in a hospital, anywhere in the world, because anything can happen in a hospital. So we already know that, we accept that. But instead of enriching individuals, we found a way of compensating those who are really in need, those who have been damaged, because there is damage, some form of damage. But now what other countries are doing, I know specifically in the Scandinavian countries, they set up panels that consist of retired judges, senior counsel, retired professors, etc. They come and assess you, and they are the ones who define how much you must be compensated for. They don't bring lawyers in between, because as I said, most of the money goes to lawyers. For instance, Dr. Letlape, and I'm sure you are aware of that, most of the money is for future medical care, and it gets paid in a lump. But once the money is paid in a lump and the lawyer took his portion, which is usually bigger, and give what is left to the patient, they are left on their own, and they come to the public sector to get treatment. We've got many of such people. Even a disabled person on a wheelchair, after paying this money, they're not going to build a house for that person, even though they've counted it in the fees, or no, this person needs a special house and all that. That person is going to live in an RDP house. They just leave them. Now, the fortunate part is that there is a case in the Eastern Cape where the judge ruled that the public sector must take care and remove the claim from, for future health care, because it's huge amounts of money. When lawyers charge for future health care, they charge for the rates in the private sector. They don't charge for public. In other words, they say in the private sector, when they are going to do this operation, it will cost this much. That's why they charge, and that's what the state pays. And from there, the patient comes to the public sector. Lastly, just to give you an example, in the Eastern Cape, we had a case, Dr. Letlape. It was given to SIU, I don't know how far it is, of a lawyer who put in claims for 9 children with cerebral palsy. That's where they charge the most. 9 children, and he wanted 15 million rand for each of them. The first suspicious thing is that children with cerebral palsy are not homogeneous. It differs, you know, from patient to patient, but he wanted 15 million. We sent the SIU there. They went to the schools where these kids were supposed to be. The teachers were shocked. How? So-and-so with cerebral palsy? This child is like any other. We don't know about this child having cerebral palsy. But there's a claim in the Department of Health. Then they went to the parents. Most of them live with their grannies. How granny? Because the granny has signed a power of attorney to that lawyer. Granny, you signed this thing and told this lawyer to come and sue us because this child has got cerebral palsy. But the teachers are saying, no. The paper I signed is for people from SASA. Somebody came here and said, I must sign this paper so that they get child support grant for the child. And I very readily signed. That is a power of attorney to the lawyer to go and sue. Then it gets worse and worse. When they dug deeper, they found that some of the kids were not even born in the hospitals that were being litigated. They were just hoping that there will be no records. The worst of them all is that they were suing for children who were never born. They never existed in this world. And somehow they just hope, you know. Now, the last example of that was a lawyer who was suing 70 million rand, 70 million, for a hospital in Limpopo, where they said there was a botched circumcision. My curiosity, Dr. Letlape, was, I know that botched circumcision happened, even within hospitals. They do, even by doctors, even in practice, you do make a mistake. But my question is, if there is a botched circumcision, if it cost 70 million, what was the botching? And I said, maybe 70 million is for an amputation. Maybe this person's manhood was completely amputated. My second curiosity was, if they amputate your manhood, how much does it cost? Money-wise, what is the monetary cost of your manhood being amputated altogether? So because of this curiosity, I phoned the MEC and say, go and get this file. And I took the file, I gave it to Professor Taole Mukwena. He's the present health umbad. He was still the professor at Steve Biko. He went through the file. I knew what was in the file, but because I'm a politician, I wanted professional. Before I came out to attack, I needed professional help because they will just say I'm working like a politician. And the report he wrote was that this man must thank the healthcare system for saving his life. No circumcision was done. He had a severe phonias gangrene because he was HIV positive, not on ARVs, not taking care of himself. I don't know why that lawyer did that. And we wanted to take him up. Same week, we got a claim for 25 million, also from Limpopo, for a person who was already 19 with cerebral palsy. And my curiosity was, until he reached the age of 19, how was he living? And I sent people there. When they arrived, it was in Fraser Hospital in Venda. A nurse called them and said, I was in this hospital when this fellow was born 9 years ago. I remember the birth very well. There was no complication. I don't know what the cerebral palsy is about. And because this man stays in the village, he has booked for a license in 2 weeks' time. But the government is being charged 25 million for cerebral palsy. Some of the claims is that he can't even wash himself, he can't do anything. So in both cases, we phoned the lawyers, wrote them, and say, please send your patient for examination. Before we pay this man, we want to examine. And they withdraw the claims immediately. They just withdraw them and disappear. So the solution here is no false claim finally. But the present one, before we have no false claim, where nobody goes to court, but you compensate those who are damaged. Before we do that, we need to put up a team of investigators and lawyers. Any claim before it gets paid, it needs to be investigated in this manner. The other question I want to answer, Chairperson, I know I'm really running out of time. Maybe let me jump to the issue of another pandemic. There is no chance that the world will not face with another pandemic. We know it's coming. It's not good words, but it's reality. Because of 3 reasons. Number 1, antimicrobial resistance. We are giving antibiotics. The farmers are giving them. There was already a committee set up in the UN to deal with this matter. Many people are becoming antibiotic resistant. And once they become antibiotic resistant, any of the microbials can become a huge pandemic. That's the first thing. The second one, climate change. Because of climate change, we are starting to see diseases which we never saw before. But the third one is the behavior of human beings. We are displacing wild animals from their habitat without replacing them. A good example is what happened in Archaican Hospital, Dr. Zomo. You know, in Chatsworth, when monkeys invaded the hospital. I've just heard that monkeys are invading somewhere in Garankua. When I called the Department of Environment, they found that there was a housing development somewhere in Chatsworth where monkeys were displaced by human beings to put that housing settlement. And they found their habitat in the hospital. So we called the environment to relocate them somewhere. So some of these issues are caused by us as human beings. And then we come and complain. Let me finish with mental health. I'll skip the others.
2 minutes.
I'll finish in less than 2 minutes. Dr. Letlapi, I understand it was asked by you. Perhaps as a nation now, not only as a department, as a nation, we need to come together to think about this mental health. It's a pandemic already, and it's mostly driven by a drug called crystal meth. Many of you here know cocaine, heroin, kids smoking benzene, sniffing benzene and all that, coming disorientated. Here, crystal meth, you don't get disorientated. You get mad, if you allow me to use that word. They come to hospital in chains. And a doctor told me that, look, during your time on Friday in a hospital, when you get to casualty, there'll be people there bleeding because of stab wounds, gunshot wounds, motor vehicle accident because of drunkenness. They say, now come to a casualty unit in a government department. You are going to find people on crystal meth. Their families don't even want them anymore because they get scared about what they've done. One of the statements I make, I don't know whether I made a vain statement. I say this massive GPV, where women are just attacked like this and children. Many of the people who do that are not normal. They are on drugs. And until we go to deal with drugs, and Dr. Letlape, I know I'm touching a raw nerve when it comes to you, because this just happened to your daughter. I'm sure you are aware. What happened to the daughter of Dr. Letlape, who was butchered like, no human being must see that. No parent. I don't wish to any parent like what happened to him, but it happened. And I'm not saying in this case it was drugs because I don't know. I'm just giving an example that when you see a man butchering a woman like that, that cannot be normal. These are not normal human beings. And there is something we must do about it. In my previous department, I said this because we know who's bringing crystal meth in our country. But as a nation, when we mention these things, they'll tell you are being xenophobic. We know, I know, I was in Home Affairs, I know who's bringing crystal meth in the country. Please allow me not to say it now. But it does happen and we know it. I even asked the police that we need to form a special drug squad about this thing. There ought to be a drug squad in South Africa. Otherwise, we are not going to be dealing with this problem. I know my 2 minutes is over. Yeah, half a minute, half a second. On the other one, I forgot something important. On litigation, Dr. Letlape. Most of the litigation happens in obstetrics and gynecology, pregnancy and childbirth, because giving birth to a child can be very complicated. Now, what's happening in South Africa because of this uncontrolled litigation, apart from fraud, the gynecologists who are being litigated are forced to look for insurance. Now, to open a private practice as a gynecologist, you need to pay 1 million rand insurance. Is it still 1 million? It was 1 million when I was in health. That's more than 5 years ago. Before you open a practice as a gynecologist, you have got to put 1 million on the table just to insure you. What are the results? Doctors in private practice are refusing to touch pregnant women. And all the pregnant women are going to public, even rich ones. Some of them come and ask and say, I've been going to Dr. So-and-so as my gynecologist. Now I'm pregnant. They say he can't touch me anymore. What's going on? Because he's scared that he's going to be litigated out of practice. So many don't touch a pregnant woman sent to a public hospital. I'll only go to gyne. Before I left health, I remember a small town here in the Western Cape. If I'm not mistaken, it's Beaufort West. It was counted in the papers where there were only 4 gynecologists in the whole town. They all closed shop and left. And there was not a single private gynecologist. And every patient has to find a way out. How will women survive under these conditions? So we need to move very fast, and we'll come to you to change the law to no fault claim, and we would like support from you. Otherwise, we'll never have a healthcare system in the country. Thank you.
Thank you very much, Dr. Mtswale, the Minister. We could still give you more time if time permitted, but we have to round up. Don't worry, you don't have to leave. We'll just round up as a portfolio committee. Honourable members, you might wish to come back, but we'll use some other time to really get more clarity on these issues. I'm glad that Dr. Mtswale touched on the issue that was raised by Dr. Letlape on the issues of GPV and femicide. There's members who have been requesting here, honourable members requesting this presentation to come on your emails. Please, on the WhatsApp group that has been created by our secretary, send your email addresses that you can then receive this presentation. Number 2, we will have to convene as a portfolio committee tomorrow at 12 o'clock to reflect on this report and therefore adopt or not adopt. Hopefully we'll adopt it, because before we get into the budget vote on Thursday, this must already be forming part of the programs and the report to Parliament. So we will meet tomorrow at 12 o'clock, hopefully for an hour. The meeting will be at room 120. in this building that is across here, the building where ministers have got their offices, ground floor. Yes, that's where we'll meet tomorrow at 12 o'clock, honorable members. 12 o'clock, we hopefully will be finished by 1 o'clock. We really have to be there so that we can complete this procedural event before the budget vote on Thursday. I'm sure members are aware that there's a budget vote on Thursday at 10 o'clock at the Good Hope building, Good Hope Center building, starting at 10 o'clock sharp. For the members who may not know where that is, please get those who know to show you now so that you do not get lost and come on time, because your party might wish that you say certain things about health, and therefore the slot will be available. So with those, honorable members, we then come to an end of our meeting. Unless there's something else. No, that is, I always confirm that she's a very procedural lady. Now she agrees that we can then close the meeting. Thank you very much, honorable members, and thanks to the Department Minister. Thanks for finishing off and rushing to finishing your cabinet and rushing to meet us. We'll meet again with the members tomorrow, and we'll meet the department and all of our colleagues on Thursday in the budget vote. Thank you very much. The House is adjourned. No, we want to reflect on you. Thank you.
Mr. Chair, could I just confirm the venue for tomorrow is that room 120? In which building is that? In 90 Plain Street.
We'll send a notice on WhatsApp, but it's this building behind us.
Thank you very much.
Ground floor.